Well, good afternoon or morning, everyone, depending on where you're joining us from. Thank you for taking the time to participate in our Team-Based Care Learning and Action Network education event. This is being brought to you by the Regional Chronic Disease Collaborative Partners, and we are welcoming the Wyoming Primary Care Association to the Regional Chronic Disease Collaborative. So welcome, Wyoming. My name is Patty Kasednar, and I work for Mountain Pacific Quality Health. And we have several great presenters who are going to share best practices around re-engaging your patients using team-based care. So before we get started, I wanted to let everyone know this is a Zoom meeting, not a webinar. So you are able to participate by coming off of mute and chatting in any question or chatting in using chat to ask questions. But we really want this to be interactive. So go ahead, once any questions you have, put them in chat and we'll address them as we go. If you aren't speaking, we do ask you to mute your microphones just so we don't have that background noise. So here's the agenda, a quick overview. We're going to talk about team-based care, what the elements of team-based care is. And then we are going to talk about how to use some standard workflows and team-based care to re-engage patients. And then we have two wonderful practice presenters who are going to share their innovative approaches to team-based care and re-engagement. And then we'll share some strategies for how you can add value to your team and as a team member. And then, of course, we have leaving in action because we always believe in assigning homework. So just to get started, so we're all on the same page, team-based care is, everyone benefits from team-based care. So team-based care is just a collective of care team members providing care either within your facility or including partners outside of your facility, but everybody working together with the patient at the center. And for patients with chronic disease, team-based care approaches can greatly help patients with self-management, help them improve outcomes, reduce progression of their conditions, and improve the patient experience. So re-engagement objectives, what we really wanted to address today is what we heard over and over again when we talked to clinics about what their experiences were and some of the barriers. Was really about the realities of COVID was that it was really difficult to re-engage patients in getting them back in the office, really is basically what we're talking about. So what we're going to hopefully do and share with you are ways to do that, how to help re-engage patients, and then some examples and strategies that you can put into place. So our guest speaker is brought to you today by the Wyoming Center on Aging. They are actually, our guest speaker is funded by the Wyoming Center on Aging, and they very gratefully made her available to us. So we wanted to thank them for making this possible today. So our presenter today is Faith Jones. She works for Health Tech, which is a health consulting firm. And you can read her whole biography, but let me tell you, she has huge amounts of experience and we're very lucky to have her today. So I'm going to turn it over to you, Faith, and just let me know when you want me to advance the slides.
Great. Well, thank you. Thank you very much for that. So yeah, you can go ahead to the next slide. So I think we're going to go ahead and just get started with why are we doing this? Like why, right? So what's been happening in healthcare even before COVID, but COVID actually just magnified all of the issues that were kind of out there. But I know that you all probably have seen lots of times the triple aim, right? And the triple aim kind of morphed, like I said, even before COVID, kind of morphed into the quadruple aim. And I know that the quadruple aim, and the quadruple really means 4, but I still like to use the triangle in looking at the the reason and the rationale behind what it is we're doing. So it really is about better health for the population. We're going to be talking about that chronic disease population specifically, better care for individuals, each individual, and what it is that it means to them and what their care means. Lower costs through improvements. We are going to be talking about some of these health promotion types of things, health management types of areas. And unfortunately, those were some of the areas that during COVID people neglected. And so that's why we're going to be really kind of working through that, because when we work in that area, in that space, it's been proven, Medicare's proven that it actually does save money for particularly the Medicare system as a whole. But in doing all this work, we cannot forget that work-life improvements for those delivering care really is at the center of everything that we're doing, and making sure that we can try to prevent burnout or at least minimize it as much as possible. We just can't afford to have people leaving the healthcare profession in what's happening today. So that's kind of the background. That's the why. That's the what it is that we're doing. So go ahead, next slide. So why is it that we want to re-engage people? Why do we need to re-engage people? Well, it's because they were a little disconnected, right? So the quarantine, right? Being in isolation, the fear of illness. Again, we're talking about this population of chronic diseases, and you heard on TV, right? These are the people who are, got the most sick with COVID. So they're really tried to just stay home and really isolate themselves in quarantine so that they didn't get sick. And even after vaccines came out, they started getting their vaccines right away. We had a really good uptake in this particular population with getting vaccinated, but people still got sick even after vaccinations. And so it was really just a huge fear factor. And then before you know it, time really just flies by, because I don't know about you, but are you all ready for Christmas? It's right around the corner, right? So time just really flies by, and you really become unaware of how much time has really passed and all of those routine types of things that you needed to take care of. And they're like, wow, really? It's been that long? Yes, it has. So we're going to talk about re-engaging people and how we're going to be doing that. And by looking at and identifying those gaps in care, the annual wellness visit, we're going to talk a little bit through that about how that could be a really great startup, particularly starting the conversation now that January really is right around the corner. And a lot of people start with it's a new year. Let me do this, let me get back into what's going on, like all of those kinds of things that are out there. So actually timing, this will be also a really good time with that. And then how do you follow up on that preventative plan? Those people who got their annual wellness visits, maybe even before COVID really hit, likely didn't follow through on that preventative plan. So what's out there? What's still hanging out there? And how can we, again, full circle back to those gaps in care? So that's what we're going to be talking about. Okay, next slide. And remember, the middle of that is that work-life balance, right? And that work-life improvements. We do all that through team-based care. Team-based care, these are the elements of team-based care as outlined by Patricia Mitchell. And it's more than just we all get along and we all work together as a team. No, there really are elements that we need to be talking through to really get team-based care to work to its best. Number one are those shared goals. So do we have shared goals? Does everyone understand what it is we're working towards and why? And then those clear roles. This one always is fun for me. When I go into lots of practices, I implement care coordination programs around the country. I've implemented about 108 programs in 17 different states. And it's really fun to just kind of quiz people, so to speak, and ask people, tell me about your role. Tell me what your job is. And then asking them, okay, so who else has this job? And then what kind of role if you're an MA, what's the role of the RN? If you're an RN, what's the role of the MA? And sometimes people really can't differentiate. Taking the time to really understand these clear roles is incredibly helpful so that everyone knows what's going on, what's expected of them. Especially if you've had a practice that has been so tight and people haven't left and it's been a solid team for so long, a new person comes into that team. we often just like, well, we all just know. And so we expect you to know without ever effectively communicating with you. And you definitely need to have that effective communication, because how else is it that you built trust amongst your team? It's because you were able to effectively communicate. And so when you're bringing new people into the team, this is a really important thing for everyone to stop and say, what are our goals? Do we know what they are? And what's everyone's role, and how are they different, and what can we expect from each other, and how do we communicate, and what are our communication strategies that we use, and then that we build that mutual trust. And of course, everything we do in healthcare, we do need to make sure that we can measure our processes and measure our outcomes. So these are those key elements. So I'm going to use this theme throughout, as we go in and talk with each one of those areas around annual wellness visits and care coordination and all of those pieces. I'm going to ask these questions again, and I'd like you to be thinking about them for yourself in your own practice. It's like if somebody walked up to you, like me, if I came to your practice and I walked up to you and I said, tell me about the goal of the delivery of care in your clinic. Will I get a deer in the headlights look? Or will people go, oh, yeah, this is our goal. This is what we do. Right? So just kind of understanding what that looks like. Okay, so next slide, please. So now here's and I know that Patty already kind of alluded to this in the beginning, but who's on your team? This is the other thing that we need to, again, not take for granted, not make assumptions, but actually think about these things. And right in the center at the top, the most important team member is our patient. Each patient, they are a huge member of the team. So as we go forward and we start looking at team-based care, what's the patient's goal? What is it that the patient wants? I like to use that 4M model of, what matters most to the patient, and kind of figuring those pieces out. We're not here to tell the patients what to do. As an entire team, with them at the top of this team, we are here to ask them, what help is it that they need to achieve the health goals and the life that they want to achieve? And that's a different way of looking at the world sometimes. We have been in the telling people what to do mode for so long in healthcare. I've been in healthcare over 40 years now. It's hard to say that out loud. But we need to really change that piece and figure that out. So who are on the team? Obviously, we have family members, caregivers. We obviously, even if we're in a clinic, we still need to have on our team those discharge planners. What happens to those patients who get admitted? How do we know that one of our patients is admitted? In some of our models of care where we have hospitalists and those types of things, we sometimes can have primary care providers who didn't even know their patients were admitted and didn't know that they were in the hospital. So that's a really important piece. Pharmacists are a key area. Medications are a huge part of what makes people come back to the emergency room or get admitted. They put them in a bucket, which I read an article not too long ago, and they just put them all in one big bucket called medication misadventures. I really liked that because it's like you took too much, you took too little, they interacted, you ate with a particular food that doesn't go with. So all kinds of things can happen. So we definitely need to have pharmacists on our team. Of course, we have the physician or the nurse practitioner or that provider. That's a key part of the team. And some of our physicians and providers are really great about understanding that they are part of this team. They make a lot of the lead decisions when it comes to the treatment plans and those types of things. But really, those decisions still stem from the fact of what is it that the patient wants. And so that's a key role to make sure that happens. And of course, in our clinics, we have our medical assistants, we have our nurses, we have our care coordinators, we have our patient care techs. I've worked with organizations that have social workers and, community resources, all of these pieces, and they all have a different role. They all do something a little different, but they had a really hard time actually articulating what the difference was. As a patient care tech, you might do one thing, whereas a medical assistant might do something else. But in some organizations, patient care techs and medical assistants do the same job. The nurse, you may have RNs, you may have LPNs or LVNs. And so kind of figuring out all of these pieces. So first of all, identifying who's all on your team, and then trying to figure out what is everyone's role and how do we all work together. So next slide. Because having everyone on the team on the same page is critical. So we start with that what matters most. And again, the what matters most to our patient and making them a part of those goals and figuring out what goals it is that they want. And so once you've figured out all of these people that are on your team and those all of those community resources. So when we talk about community resources, sometimes I hear people, because we all live in small areas or have the tendency to think of all of the places that we are as rural and frontier areas as well. We live in a really small town. We don't have very many resources. And I beg to differ. When you get there and you start to kind of peel back the onion, you really do figure out that you have a lot of resources. How do you use them? How do you incorporate them onto your team? How do you communicate with them? Okay. Do team members change based on what's happening with a particular patient, or do they change based on different patient populations? I mean, of course they do. And then the dynamics within some of those teams also changes. So really sitting down and looking at your team, you can start really small, the team that you work with every single day, the team that's there at the core always, and start asking them, how do we communicate what our goals are? Do we have communication boards? Do we have morning huddles? Do we have heavily into email or communications that we send out? Nothing is right or wrong. It's what works in your culture, just so long as you really can communicate these things and keep up with the changes so everyone understands. And then again, is there a model that you use? And I really think that sometimes thinking about what that model looks like, especially when you bring new people in, and maybe even before you bring new people in, when you're in the hiring process, asking people that are going to maybe come into your organization, what is their philosophy of care, or what types of models have they used? And maybe they have their heart set on a particular one, or maybe they're like, well, I'm not really sure. I've used various models. So then you can explain the model of care that you use and the philosophy of care that you use amongst your team. That's how you get the right team fit. You can't assume that people are going to come in and, yeah, they're a really good nurse or they're a really great pharmacist, but if their model of care, philosophy of care does not blend with yours, these are the kinds of things you can do on that hiring process. Now, if you don't have any of these things in your practice yet, no worries. But one person shouldn't make this decision. This is a really great time to really bring the team together and have the team talk about what models of care are we looking at? What do we want to use? And so, as you may know, Age Friendly does the IHI, the Institute of Healthcare Improvement, put together some of the age friendly framework. And I work mostly with the elderly population, so that resonates with me. But I think that that framework resonates with lots of other populations as well. But that's that 4M model that really does the philosophy of care, puts the patient at the center. So, what matters most to the patient, what matters, that's the first M. And then how are we working with the patient around medications, around mentation, and around mobility? And so that mentation word can kind of get people, a little bit like, what do you mean by that? So sometimes that's like mood. We talk about keeping people from issues with depression, so some of that socialization. Think about it as mind, just like your mind, and keeping that sharp. All of those things are part of that model of care. So once we're all on the same page and we use the same language and we have effective communication, that's really key. So I always think that that's a great place to get started as you go down that road. Okay, next slide. So now let's talk a little bit about, I'm not going to go into a lot of detail here, but I put all the detail on the slide because I think it's important for you just to have it. But let's talk about that annual wellness visit, what it is, what it isn't, and using the team-based approach to care. How can you re-engage people through the annual wellness visit? So the annual wellness visit is a visit that is done under the team-based approach to care. I want you to look at that third bullet. Can the annual wellness visit be done by a physician? Absolutely. Can the annual wellness visit be done by a physician assistant, nurse practitioner, clinical nurse specialist? Absolutely. But does it have to be? No. And that's the piece when we start focusing on that piece in the middle, right? That making sure that we are paying attention to those workplace environments, workplace improvements, and work load using other medical professionals. And so you can see this is the definition. Lots of people qualified to be able to be the one to actually do the annual wellness visit. It is not a physical exam. There is no physical exam as a part of the annual wellness visit. So a care coordinator, a registered nurse, some practices have a pharmacist doing it, lots of different people doing the annual wellness visit. It does a couple of things. So say you have a registered nurse who is doing that annual wellness visit. One, it allows that registered nurse to practice to the highest level of their licensure, which is a rewarding part of your career building. And you get to do the job that you went to school for and to do. And it also takes things off the plate of the primary care provider. So it allows them to be able to do other pieces. So that's why it is so valuable from a team standpoint that we use the team-based approach to care. Okay, so next slide. So, in doing this, we want to talk about as a team what's the goal of the annual wellness visit? Does everyone understand? What are the clear roles? Who's going to do what part? Who's responsible for what? The communication, how is that visit documented? And very importantly, how is that visit scheduled? Because you also don't forget about those front office people who are a part of your team. There's nothing that's going to disengage a patient quicker than if you're out there with all kinds of campaigns asking them, please, please, please make your annual wellness visit. They call for their appointment and they say, I'd like to make my annual wellness visit. The people at the front desk, they say, you mean your annual physical? No, they do not mean that. So making sure everyone understands the effective communication around that and what that looks like. And then where are the decisions made? Who gets to make the decisions about putting things on that plan? And what is it that you're measuring? Understanding that the effective annual wellness visit can take an hour to an hour and a half if you also add in advanced care planning, which we're not actually going to talk about here today, but all of these things. So understanding what it's about, understanding the goals, the clear roles, we can all be there to make sure the patient gets exactly what it is they're looking for. So next slide. So the outcome of an annual wellness visit, next slide. So there we go. The outcome of the annual wellness visit really is to provide the patient with an outline, right, of their entire year. They do not get sick. They have chronic conditions, maybe. They have diabetes and hypertension. Those are their chronic conditions. Those are pretty common. So they're getting their annual wellness visit done. Say they got their annual wellness visit done last February. And so you can see we changed the dates on those. I just kind of leave it as so in March of 2022. These are all the things they're going to do to maintain their health. It's about maintaining their health. All of these things that they're going to do, this is an example sheet. This is what's lined out for them for the entire year, even if they don't get sick. So I think that's an important piece to say, this is what we're looking for. So we get to spread this out. And so we want to keep track of other appointments. So for example, maybe they have to go see the eye doctor in April for their glaucoma check because they have diabetes. Maybe they need to see the diabetic educator for that self-management training that they get. And so we kind of put that out a few times throughout the year, making sure they have that, see the dietitian for their medical nutrition therapy. Oh, and it's time for them to get their mammo in June. So having this out on a calendar can really help us to make sure, for example, that time doesn't just get away from them, right? So that disengagement that happens because really, has it really been that long? Yes, it has. And this is when it's time to do these things. So lining all of that up for people really helps them to go, okay, I've got it. There's stuff I need to do to pay attention to my health all the time. And then we're looking at what's the goal. Well, their goal is they really want to increase exercise. Okay, so what does that look like? And then what does those interventions look like? So what are you going to do to increase exercise, right? Oh, maybe there's a walking program they can go to. Maybe giving them an intervention of, hey, let's see about finding a walking buddy, or, what's happening out there with them so we can make that all happen. So understanding with these chronic conditions, there's a lot we need to do even just to stay healthy, maintain our health with these conditions. So next slide. And keeping in mind that all of these things about re-engagement around the annual wellness visit are about building that relationship with the patient. So that's the key. The key is that relationships, because it's from relationships that really is the foundation of trust. So remember, the patient is that main person on our team, and building trust on our team is a really important piece. So lots of times when we want to start to re-engage for the annual wellness visit, instead of just doing cold calling, so to speak, for people, it's like, oh, it's time for their annual wellness visit. Start with those patients you already have a bit of a relationship with. So start with those patients who maybe are already in your care coordination program, your CCM patients, those people you've been reaching out to maybe just by phone or whatever that looks like. And you can say, hey, Mrs. Jones, guess what? You can come in and see me, and it's time for you to come in and have your annual wellness visit. Let's get that scheduled. So starting with those people that that you have some relationships with is really helpful. And the same is true for the transitional care patients. So patients who have been in the hospital and they're doing within their 30 days of that transitional care, they're getting towards the end of that. And you've been doing all of this care coordination for them for the last 30 days. Giving them a call to say, you know what, now that you're on the mend, let's go ahead and do that annual wellness visit. So really picking those things up makes some sense. And then the opposite that you can do is you can also, when you do the annual wellness visit, if somebody is not in your chronic care management program, that's a great time to introduce that, to start building that relationship. So next slide. You were good, Patty. So start building that relationship by getting them engaged and getting them enrolled in the chronic care management program. I found that we had several practices who actually were able during COVID, when they worked, they would call patients who qualified and they would say, you know, I know you're staying home, you're not coming in. We get all that, but we want to stay in contact with you. We want to stay in touch with you. We have a program called Chronic Care Management that we can stay in touch even when you're not coming in to see us, so we can make sure you're doing okay. I actually had a couple of clinics, one in particular in Montana, that recruited over 30 patients in the first couple months of COVID, because these people were home alone and they were isolated and they couldn't get out, but they still wanted connection. And so that's another way to kind of be thinking about that. So what is chronic care management? This is an acknowledgement that came from CMS. All of us who have ever worked in acute care, in primary care, we know that in primary care, there's a lot of stuff we're doing every single day that isn't a part of the actual visit with the person in front of us, particularly nurses that work in a clinic. So you're busy, busy, busy. But Medicare actually put it in writing. So that's what makes it even more exciting, that they said, hey, you know what? We figured out that there's a lot of work that's non-face-to-face work that happens in primary care that is outside of the visit. So maybe, just maybe, when we pay for just a visit, we're not paying enough to maintain that primary care. All of us who've worked primary care say, of course you're not. So, but it's a great, because they actually acknowledge that. And so that's what CCM is really all about. It's about coordinating all that care in and around a patient that's outside of a visit, but it really does help us to make sure that we can stay connected to them. So next slide. So if you're in a fee-for-service clinic, we call them, you get to use the ones in the blue box, or CCM chronic care management codes of 99490. And that's making sure that there's at least 20 minutes of clinical time per month. Then there's 99439, and that's an additional 20 minutes of care coordination for a max of 2. Now, I know we have people from rural America here. And so in rural America, if you are in an actual RHC, so a rural health clinic, or an FQHC, you still can do CCM, but they actually call it care management, and they wrap it all around, and they say it can be chronic care management. It can be complex chronic care management. That's the triple free CCCM. Or it can be principal care management, which is about one particular diagnosis, or it can be behavioral health. They don't care which one you're doing. It's all called care management. They put them all together, and there's one billing code that you're allowed to code for that, and that's a GO 511. So there's regular CCM, there's complex CCM. All of these things are that non-face-to-face time. But the good news is it's still about connecting with people, and it's still about making sure that we're there. So next slide. So when we're using the team-based approach to this, we want to make sure, one, does everyone understand what the goals of CCM are? How is it that we have these clear roles, and who is responsible for making sure that we're getting the consent? Who is responsible for time tracking? Who's a part of all of those things? How do we communicate? Where do we document that care coordination documentation? What's happening out there? Are there any protocols in place already so that we don't have to ask the physician or the provider for every single order? It's like, no, here's the protocols. I trust you. You understand your job. And these are the protocols. So go ahead and let's kind of get some of these things done. So that really works out really well. And then, of course, what are we measuring? The beauty of CCM and part of the re-engagement of that is that you really should be care coordinating for a patient every single month. The cool part about this is we tend to take care of people when they have a need. We're good at that. We're fixers. We're in healthcare. We're fixers. That's great. But in addition to that, we should be being proactive and looking for those additional care gaps that the patient might be needing. And so that's kind of what we're looking at for that. So the next slide. So when we talk about re-engaging patients in CCM, we're really looking at taking those current patients, the current CCM patients, and trying to contact them every single month with a purpose. You should always have a reason. Just calling the patient and saying things like, hey, just to let you know, just calling to see how things are going, that isn't really helpful to a patient. To call them and to say, hey, looking at your preventative plan, it's time for this or it's time for that. Those are the kinds of things that continue to build that relationship. And then, of course, you're always looking at that future recruitment so that we can build that relationship even more. And then the next slide. The next slide is that one around TCM. I've already talked a little bit about this. TCM are those patients who have been in the hospital and they get discharged from either a hospital, from a swing bed, from a skilled nursing facility, and they go back home, making sure that we set them up for success. How do we reach out to them? How do we talk with them? And you can see that is a full 30 days of care coordination to really support them in their whole daily living. So that's what's really an important piece, that we're making sure that everything they got, that they needed, that they got from being discharged, and it kind of went from there. And so the next slide, the team-based care for this is, again, asking those same questions. And that is, what is the goal of TCM? Does everyone understand who's responsible for scheduling that visit, making sure that the pre-visit planning happens, making sure all 30 days of care coordination happens? Where are you documenting this? What does that look like? So everyone can be on that same page so that we have a really great handoff. So we never, ever have a primary care provider walk in a patient's room and go, Mrs. Jones, you were in the hospital? I didn't know that. We never want that to happen. And all of these things are to prevent those readmissions, and all these tasks are very time sensitive. So next slide. So how we engage with people here is we need to know our patients' migration patterns, right? So we know about our local hospital, but what about the regional hospitals? Do we know the discharge planners there? Have we built relationships with them? Are you going to be top of mind? Will they call you if they have a patient of yours? Or are you calling them every couple days? Hey, do we have any patients in the hospital that see Dr. X? What's going on? All those kinds of things. And don't forget those local skilled nursing facilities, so your regional hospitals. How do you build those relationships so that you can manage those really good, warm handoffs, as we like to call them, or I like to look at it as report? How do you make sure that you're giving report on that? So with that was a lot of information, but thinking through some practical examples of how you can re-engage people and some of the target audiences to start with that re-engagement can be really, really helpful and successful as far as that goes. I'm not sure, do you have any questions, Jeff, that came up in the chat that I can answer at this point?
Yeah, we do, Faith. We've got a question from Sabine here, and she asks, do you find that patients are more engaged in participating in their care when a team approach is used? And are there any studies that show better health management when patients participate in annual wellness visits? So she's got 2 questions.
Well, the first answer to your question is easy. It's yes, if if everyone on the team is actually on the same page, because there's nothing more frustrating to a patient, particularly when we're asking them to change their behavior. When I say to the patient, Mrs. Jones, you probably, let's talk about how much you're, smoking or exercising or whatever, because it's really important that you stop smoking. Let's just pick that one. It's really important that you stop smoking. That's the most important thing. And then they meet with someone else on the team and they say, and the other person on the team says, Mrs. Jones, you're doing okay. But the most important thing that you could be doing is that you exercise so that you can lose 10 pounds. That's the most important thing you can be doing. Well, now when you have team members who are not giving a synchronous message, the same message, and they're not on the same page with a patient, then what tends to happen is patients go, well, if they don't even know what's the most important thing, I'm not going to do anything. I'm not going to do anything different. So using a team-based approach, when you really have not just various team members, but various team members on the same page, that is powerful. That is a powerful, powerful message. And yes, there are some studies out there, Sabine. You actually can, even if you just Google Patricia Mitchell and team-based care, she's done a lot of research around this and really kind of making sure that that happens. That's really key. And then the other part of patients being involved in their annual wellness visits, absolutely. You want to go through, and we always make sure that it's not about just telling them what to do. You go through, these are all the benefits that you get. This is what you qualify for. When do you want to do this? Having them be a part of that decision making, then they can say, yes, I want to do that. Let's do that in June, or let's put that on the calendar for July, or, I'm not interested in having that done. I don't actually want to do that. And that's respecting that and saying, okay, well, we'll put that off. We'll talk about it again next year. Fine. We don't want to badger them. We don't want to talk them into things. We want to give them the information and help them make the decisions that are right for them, not the decisions we want to make for them. So hopefully that answered your question, Sabine. Are there others, Jeff?
Not at this time, Faith.
Great. Well, thank you so much. Now you get to hear some other examples of things that are happening. So we'll turn it over to our practice presenters. Thank you so much.
Thanks, Faith. Great job. And again, you can continue to enter questions in chat for the rest of the presentation. We'll address them at the end. So it's our privilege to present our first presenter from Marcus Paskey, is a clinical pharmacist from Intermountain Medical Group here in Butte, Montana. And he is doing amazing, him and his team are doing amazing things to re-engage their patients. So go ahead, Marcus.
Yeah, well, thank you for having me. I will admit, obviously, that picture is a little old. I don't quite look that young anymore. So yeah, I'm a clinical pharmacist here in Butte, and I work in the primary care clinic. So that's kind of our scope of ambulatory clinical pharmacy. And where we're formerly SCL, now have merged with Intermountain. And I've been practicing doing kind of this ambulatory clinical pharmacy for about 10 years. And I think that maybe why Patty asked me to come is more my recent change is about 2 years ago. Right in the middle of kind of our big COVID swing in 2020, I moved over to Intermountain into the medical group there. And at that point, they didn't have a clinical pharmacist at all on site, and they had never worked with one. So, what I normally practice in is chronic disease management. So it's kind of right up the alley that Faith's been talking about as well. And diabetes is a huge part of that, but as well as hypertension, asthma, COPD, and heart failure are the other big chronic diseases that we're always trying to help basically improve. And that's really what they bring us on staff for, is to help improve outcomes. It's not for billable visits or for revenue. It's really just to help improve patient care. So it was one of the things I did when I came in is I basically reached out to our state Department of Health in the diabetes program, and with some other work we've done in the past, knowing that basically what I do is team-based care. If you don't have that belief, then I'm not going to have a lot of work. But then also trying to get it going, get it used, and get some good outcomes to really start showing us. So when I reached out, we started this project, and your timing was perfect there, Patty. So we did this project that really was about trying to engage team-based care in a practice that had essentially been a 30-year-old private practice that had molded into a system practice with a majority of more seasoned providers and then some younger providers, but a lot of them just had never worked with anybody outside of maybe a care manager or a diabetes educator. And it was a very kind of, I'd say, an old school one-track mind at first. And so what we basically did is we came in and said, we want to just show what team-based care, how to make it more effective and how to get people into team-based care, but then wanted to take that next step and say, well, not only team-based care did we get people, but did we actually make them better? So the purpose really of our project that we worked through with our state Department of Health and diabetes program was to just get more referrals. And I teamed up with our local diabetes educator as well. She had been there for a while, so that wasn't a new service, but her medical group and outpatient referrals were lagging. So we kind of worked together to see, can we really engage this primary care clinic, which was internal medicine and family practice, to kind of go outside of that normal, siloed physician visit. And so what we did is a few different things that I'll just quickly go over. But I have kind of really enjoyed listening to Faith. I just want to take her on the road with me everywhere I go, because I don't have to say the things she did. She said it exactly, as far as that engagement and the getting everybody on the same page. I mean, on the boots on the ground perspective, that is 100% what made ours successful. And in my other places I've worked, that's also been the success. When we have anybody on a, kind of that ancillary team that kind of sits in their office and waits for work to come, it just doesn't come. So we really do need to get everybody on the same page. And like the daily huddles was probably one of my most effective ways of every day, there I am saying this, sometimes the same things over and over again. But we really just tried to say, let's get people in. And then once we started getting some people in, then we can show the teams, but then of course the patients, and then of course, and then as well as our kind of our big decision makers and leaders, that it is worth having these extra services on board. So you can kind of see there on the left, that was the project we did for referrals. So we had in the I guess it was about an 18-month time frame that we actually looked at. We had 172 patients that essentially walked in our clinic doors that had an A1C greater than 9%, so very uncontrolled. And of those, we got 74% either referred to diabetes education and or clinical pharmacy. And a lot of that as well was kind of saying, okay, you have this huge team, and we also have care management that helped us out a bit too. Who does what? And that's, again, part of that, just making sure we were out there all the time, really letting these clinics know what we do. What I do in my role is a lot more medication management, but I would team up a lot with our diabetes educator, and we do joint visits. So that way they're not hearing one person for a full hour. And then also kind of getting that high effect of, okay, we're gonna work on the medicines for a few minutes and we're gonna talk about diet and lifestyle. And it just kept the mind fresh too. So we were pretty happy with 74%. We always have a few holdout providers that just don't really refer. So we were very excited with that. And then being especially new for me in the service, it's always good to prove kind of your value to your system. So of that time frame, 66 of those patients I was following with, and then had the opportunity to get repeat A1Cs by the time our project ended. And so we started with an average of about 10% and dropped them on average down to 7%. And then 95% of them, we got less than 9%. So there's always those few that you just unfortunately can't get quite through to, but we had great success. And I think that was kind of really what I wanted to do, is to essentially show that having me on staff, having a pharmacist on staff, is something that is valuable. And we also have pharmacists throughout our team that are kind of cross billings in Colorado, but they also were fairly new. So it was a good system show. Do you want to go to the next slide there, Patty? And this is the only other slide I have, which when Patty kind of talked to me about your guys' theme today, again, I I don't think I could say it as well as Faith did. She did great at just, I think, showing like what the importance is to really get patients engaged. And I think it was unique to come in. It was obviously a risk to come in a new clinic in the middle of a pandemic. But then how did we get those people re-engaged? And I kind of tried to just list out some of the big points of what made this a little different, especially coming off of, you know, the lockdowns and the quarantine phases. But then also still keeping people engaged, even though we're a little bit more loose in that world. So like I said, engaging those teams was probably the most important part, getting everybody on the same page, all the way down to our nurses and our MAs, so that they, again, top of mind awareness of the people on the team. And then what I also did, kind of part of that project, is also to add a tangible service. And I think that might be one of the unique things I can say off of Faith that I think helped engage people. Is it was, what else can we offer them? And, you know, they don't necessarily, you know, want a free lunch, but it's kind of the same idea of, if you come in and if you kind of engage with us, we're going to give you this cool technology. So we use continuous glucose monitors, professional versions that I've worked with in the past. That was an amazing tool because people have seen them on TV. They are at least curious, if not really did want one. Even if it's just for a 10-day short-term period, being able to show them, this is what happens when you eat. This is what happens when you take your medication, especially insulin, where you see that really fast curve. Being able to watch that and really use that, not just for our sake of helping with medication management, but also more so, I think, for the patients. And then with a lot of new medication classes, of course, in diabetes, I think we were a fresh set of a fresh approach for a lot of patients that hadn't been on these new medicines. A huge portion of it's always cost. And being a pharmacist, we get to kind of bridge that gap a little bit between the pharmacy and then the clinic as well. I won't go a ton into it, but of course, the telemedicine, and I probably do mostly by phone after we make those initial relationships, was pretty amazing to keep people engaged. Because if they, whatever their reasons were, we live in Butte, we get a lot of snow. People like to use that as an excuse to not come in, and that sometimes is where they fall through the cracks for 3 to 6 months. But we just can essentially do a lot of the same stuff, at least 90% of follow-up over the phone, as long as patients are, you know, going to answer their phone and engage a bit there. And then I think that, as well as kind of part of that re-engagement, was accessibility between diabetes educator and myself. You know, we generally give out direct phone numbers. So if you have a problem, you have a question, just call us. You don't have to go through a phone tree, leave a message and play those games. And then I think people kind of get it back in the swing. We kind of use the example, it's like doing anything exercise. The hardest part is getting going again. Once you get going, you feel good, you like where things are going. And I think that's the same when it comes to a lot of these chronic diseases that we help manage. We, of course, we're just another person saying a lot of the same things. We have great physician teams, but one person saying it doesn't always mean as much as 2 or 3 or 4 saying the same important interventions people can make. We did have that collaboration with care management, of course. And then one thing that I would say that I've always tried really hard to maintain, especially in my role as a pharmacist, is it doesn't just end when we send the prescriptions and let them leave the clinic. They have to go to the pharmacy, they have to be able to afford it, they have to refill it. But we're doing actually kind of a follow-up project, which I'm excited about to kind of see off the heels of this. And I see Christelle's on this call as well, but she's kind of the project manager for us, doing another project where we're going to keep data tracking on patients that use, we have a pharmacy that's real close to our clinics, and being able to monitor in the clinic side as well as on the pharmacy side, checking in with blood pressures, more education, really a collaboration, knowing that the pharmacies and the pharmacists in the retail pharmacies are just as important part of that team. And again, that re-engagement, because hopefully they're seeing them at least every 3 months, but usually monthly or more often than that, depending on refills. So continuing that communication and collaboration, so that way it's not just an every 3 to 6 month physician visit, when we're actually helping people make changes and do better. So I can't probably echo as well as Faith did. I would agree with everything she said as far as that team engagement. And then when the team's engaged, the patients get more engaged because they're not just hearing it from a single person, was probably one of the big take-home points that I would also really agree with. That was all I really had. Yeah, any questions?
Yeah, so I'm gonna jump over to Austin because we're a little bit tight
Sure.
on time, but great job. Any questions for Marcus, please include them in the chat. Marcus, if you want to monitor the chat and answer any questions, that would be great. And so then it's my pleasure to introduce Austin Mills, who is works at Benefis Health Systems here in Great Falls, Montana, and she's doing amazing work around remote physiological monitoring. So go ahead, Austin, take it away.
Okay, so I'm Austin Mills, like Patty said. My main role has been quality compliance for all of our outpatient departments, but I also oversee a small care coordination team of about 7 employees that do different roles, like Faith was talking about. So chronic care management, remote patient monitoring, TCM, and whatnot. In 2021, we decided to, as an organization, that we wanted to implement remote patient monitoring somewhere within our system to try to reduce readmissions and to try to improve efficiencies. So I volunteered and decided to take it under my team. And what we did is looked at the places that we were already doing things like chronic care management. We were already reaching out to those patients and getting blood pressures or blood glucose levels or whatever over the phone, and trying to integrate this into places that could make our practice more efficient, and the staff liked it a lot more. So next slide. So this is kind of shows the interventions that we have done since we started with remote patient monitoring. We call it remote patient monitoring because it's a lot easier to say than physiological, but we actually bill the physiological codes for all the patients that are set up via Bluetooth with their devices. So what we have looked at is we started with our chronic care management patients, and then we started with our hypertension patients that we follow through our grant. And then we've done other different things by adding in different pathways like CABG and CHF, CKD, all of those different common chronic conditions that are available to our providers. At the end of the at the end of 2021, we opened up remote patient monitoring to any benefits provider can order those services for their patient and send it to our care coordinator. And then that care coordinator actually will go up to the hospital room and talk to the patient, or have that patient come to our office and set them up and do all the education that's needed. We also started gestational hypertension monitoring, which has been very successful, and we have a lot of OB patients that are currently using it. Right now we have 150 licenses. 50 of those are what they call the home kit. So it includes a tablet and then all the Bluetooth devices. So it's a kit that has everything that they would need to start monitoring that day. Or we have the app, which is a bring your own device. So we have 100 of those licenses for patients to use. So we're trying to work on just our utilization of those licenses, but I think we're doing pretty well since the beginning of the year. So next slide. So one of those areas that I talked about, so prior to remote patient monitoring, we started a hypertension program for our primary care practices. And at that time, it was all just, give the patient a blood pressure monitor, a loaner, and then they would handwrite all of their blood pressures, and then we would call them on a weekly or biweekly basis and get all that over the phone and then enter it into the system, which was very onerous on our case manager. So in 2021, we started moving all those patients over to the app if they had a smartphone, which most people do. And if they still had a flip phone or didn't have that technology, then we would still do it the old-fashioned way for over the phone. So as you can see with our hypertension program, we have made great strides with our control rates. So prior to the grant that started in 2018, we were at 58% control rate. And then prior to RPM, we were at 81, but we were still holding strong with that. As probably a lot of people in Montana have noticed, or maybe in other areas, people have been moving here, and our patient denominator has gotten a lot higher. So we are still holding our control rate, but we have almost like 1,000 more patients than we had in 2020. So with our blood pressure monitor program, we loan out those cuffs if they need it, if they have the bring your own device. And then this is how many patients we've had: 180 or 162 patients that have used the app so far for just hypertensive monitoring. And then just within the last few months, We have started working with our one of the pharmacists within our system to do medication reviews. So the care manager that monitors these patients will pick out patients that she thinks would benefit and refers it to that patient. And then the pharmacist meets with them and does a comprehensive medication review. And so we're trying to get that more integrated. We're probably pretty behind everyone else, but not having an integrative pharmacist on our outpatient side, except for anticoagulant management. Next slide. So for RPM as a whole, our utilization in 20 or year to date, we've had 298 patients enroll. 257 of those patients are use the app or the bring your own device. And then 41 of those patients are on the home kits. The home kits tend to be on for a lot longer. And then with our app patients or Go patients, we have a shorter turnaround, especially because we do a lot of post-op total joints within that day. And so we monitor them for at least 9 days or depending on whatever they need post-operatively for those patients that go home that same day. We track patient satisfaction for the program. And so the question that says, overall, I am satisfied with my experience in their RPM program. Strongly agree is at 82.6%. And then if they answered strongly agree or agree, we're at 94.7%. And then I also added on here just so that you guys are aware too, the majority of the people think that the technology is easy to use, which is what you want, especially because a lot of our patients potentially are older or over 65, at least for the home kits. We have a lot younger population with the app. So since we have so many different chronic conditions that we are potentially monitoring for these patients, we decided to also add in something just like for interventions so that our case manager, as that intervention happens, can note on the chart and we can pull a report on it. So we started doing this in August. So we track now our interventions. So how many medication adjustments were made just remotely. The patient didn't have to come in the office for that. How many possible ED visits that were avoided, and then how many possible or how many hospital admissions were avoided, just to try to show our senior leadership as well that this really is working and it is a more tangible metric to look at. So since August, we've done 44 interventions that saved our hospital money as well as the patient money by not having to come in for an office visit for a medication change or have an ED or a hospital admission. Our main referral sources that we have is our hospitals program has gotten really good because we bug them a lot and we go and do kind of meet and greets and talk about data. So they core text us, which is a secure texting mechanism that we have within our hospital. And they say, hey, so-and-so in room, whatever it is, would probably be a good candidate for remote patient monitoring. And so we will do the digging to make sure we have a provider that will oversee that care. And then we will go to that patient's room and do all the education with them. We also have a lot of specialist and primary care providers that refer to us, especially for hypertension. And then our own internal case managers that do different roles, like our nurse that does our post-hospital calls. She'll identify people and then refer it to the gal who does remote patient monitoring. We also have a readmissions committee that I am on, as well as a remote patient monitoring case manager. And so we identify people at that time as well to reach out to try to get them on a program to try to avoid another readmission. And then we have, as a process, all of our same day total joints that are scheduled. We reach out to all those patients and enroll them in the app so that we can monitor them post-operatively. Next slide. So every project that we do, typically has some sort of barriers. So one of the barriers that we are coming across is patients that are referred to us upon discharge are not established with one of our benefits providers. And that makes it really hard for us to monitor them without having an overseeing physician. We are trying to work with our hospitalist group to see if maybe we can come up with an in the interim until the patient establishes with one of our specialists or primary care providers, it may be whoever is on rotation for that week would decide to oversee that monitoring if we have any questions that the nurse can't intervene on. Determining patient compliance upon enrollment. So we have some patients that would be, great candidates in theory, but they really don't want to do the work for it, or we're not really sure if they have a home environment conducive to that, or they might not have, that social support. So those kits that we give typically out, we don't want to give those out unless we know for sure the patient is in, a compliant state and will actually use it and actually will return it. So if we kind of aren't sure if they will be compliant with it, we try to start them off with the app, or even we just give them our number and they can call us and give us their readings so we can see if they actually are engaged. Because those kits cost us about $750 if we lose one. And so we want to make sure that we're being fiscally responsible since we only have such a limited number of kits. We also have an occasional delay in the return of kits or the blood pressure monitors, especially if the patient lives in a rural area. Even the kits have a FedEx return label on them, but sometimes it just kind of takes people a while to get them back to us. And then billing. So there's a lot of Medicare programs out there and it sounds really great, but actually when you go into what the process is of billing, it can be kind of cumbersome. So we are only billing right now for the home kits because those are Bluetooth enabled. And we're only using the code 99453, which is the setup code, as well as the 99454 code, which is the monthly kind of like rental fee, basically, that the patient has a copay on potentially, depending on their insurance. The patient actually has to monitor for 16 days within that 30-day period. Otherwise, you can't bill. So if you have people who are not very compliant, then you can't bill for those. And then just trying to maintain our utilization of licenses. Because with our contract with that company, I have to pay for the licenses regardless if we use them or not. And so just trying to, not waste money, but try to get as many people enrolled as possible that are appropriate. And I think that is the end of my slides.
Yeah, that's it. Thank you, Austin and Marcus, both of you, for agreeing to share the great work that you're doing. If you guys have questions, go ahead and chat them in. I'm going to just blow through these remaining slides, and then you can review them in more detail once we post them to our website. But we did identify some strategies or suggestions of additional ways to use your team members and their ideas around patient outreach. Here are some suggestions. And like Faith, like everyone has talked about, everyone in your organization is part of the team. So it doesn't need to be certain subject matter expertise or things like that. There's some things on these suggestions that anyone could do. So for patient outreach, for helping support care coordination, for performing specific services, and other ways that you could add value as a team member. And then the homework really quickly is just keep an eye out, use annual wellness visits if you can to bring your patients in, review your patients who are eligible for chronic care management and begin a recruitment campaign, or even just think through everything you heard today and identify one thing that maybe you would take up or contribute to the team in a different way. At that point, I'm going to ask, I know we're running a little bit late, but we want to provide a poll here to identify what future education topics you might be interested in. If you would please take a minute, this is multiple choice. Choose the topics that you feel you would like to hear more on. So innovative ways to utilize community health workers is one, addressing behavioral health for patients with chronic conditions, clinical inertia, what it is and how to overcome it, community information exchanges, understanding what those are and how to use them, expanding your use of community-based organizations, remote patient monitoring for hypertension and diabetes, or even just a showcase like we did today with these two amazing speakers of what they're doing in their practices around population health. And then if you have any other ideas, go ahead and chat them in for us. That would be great. And I'm going to just do that poll for about 10 more seconds. So get your voting in, and that we will focus our regional chronic Disease Collaborative will then present whatever you guys choose as our next education topic. So Mary, if you want to, yeah, are we done with that poll, Mary? I'm going to say yes. I'm going to stop sharing it. And then, sorry, I can't get out of there. And then really, again, I want to thank the Wyoming Center on Aging. These are the resources that are available today. They have a great video on collaborative practice agreements along with these other ones. And also then thank Faith and Austin and Marcus for your amazing contribution today. We couldn't have done it without you. Thank you so much. And thank you all who participated. We appreciate your time. Have a good rest of your day.
Thank you.
Thanks.
Thank you.